Okay, we are live.
Awesome. All right. Well, good morning. Thank you for attending case reviews for July. I think we have some particularly good cases to discuss. And yeah, as a reminder, this information is confidential. It's protected by HIPAA, and you should not be sharing it in any form besides with your colleagues on a work-related format. So on to the first case. So the first case, just looking over a couple things here, is about a 46-year-old male. EMS was contacted for a sick case. The dispatch was sick person, and the patient's chief complaint was shortness of breath and feeling sick. The patient was alert. His airway was open. He was protecting it, but it was noted that he had RALs in his pulmonary assessment. As for his skin, it was pale, cool, clammy, and he had weak pulses. Vital signs were obtained by fire prior to arrival, noted to have a temperature of 96 degrees, a heart rate of 122, a blood pressure of 136/97, a respiratory rate of 40. SATs initially on room air was 81%, and a blood glucose of 212 milligrams per deciliter. The past medical history provided by the patient was that he had a history of migraines for which he took Depakote. In the history that was obtained from the patient, and I think the family members as well, is that he's been feeling short of breath and ill for the last 3 weeks. He was apparently bedbound, which actually meant sofa bound for the last 5 days. And he hasn't eaten for 2 days, and his symptoms got worse today, prompting 911 initiation. This one was a little bit of a prolonged arrival for the transporting agency. Might have been it might have been a level 0 time or instance. The vital signs, which or prior to arrival, are already reported. They put him on a non-rebreather mask, and his stats went up to 93%. And the initial patient contact was in the evening at 18:01. At 5 minutes, CPAP was placed on him because of his respiratory distress. At 9 minutes, he had a blood glucose checked and a temperature recorded. It was noted that while he was laying on the couch, that he was laying in his urine and his feces. Um, at 10 minutes, he became unresponsive. His pulse was 75. No blood pressure was recorded. Respiratory rate of 18, SATs of 50%, and end tidal of 47. So at 13 minutes, they again found him to be unresponsive. Now his heart rate is recorded as 34. He was determined to be in PEA, although they do record a blood pressure here, which I think is probably right before he lost a pressure. But they record 155/115 and respiratory rate of 0, end tidal of 6, and CPR was initiated. At 14 minutes, an IO was placed, and at 15 minutes, an iGel was placed. At 16 minutes, while doing continuous CPR, they switched him over to Lucas, and he was given 1 milligram of epinephrine approximately 3 minutes after he went into arrest. At 17 minutes, he started to have some secretions. I believe there was some mention of vomit, and they suctioned him. At 18 minutes, on a pulse check, he was noted to be in VFib. They shocked him at 200 joules. The subsequent pulse check after that, 2 minutes later, at 20 minutes, he was given a milligram of epi, and next pulse check, he achieved ROSC. His heart rate was documented as 91. His blood pressure was 109/60, respiratory rate of 8. SATs at this point with an iGel is 87%, and end tidal had spiked at 95. At 27 minutes, he was given 250 milligrams of ketamine. And at 28 minutes, he was given 100 milligrams of rocuronium. He was intubated with video laryngoscopy at 29 minutes, bougie, placing an 8OET tube with first pass success. Shortly after he was intubated, he again lost pulses, and CPR was initiated at 32 minutes. He achieved ROSC shortly after initiation of the second round of CPR, where his Documented heart rate was 34, blood pressure 154/40, respiratory rate of 19, SATs of 56%, and end tidal of 47. They waited, it looks like about 4 minutes, where they moved forward with post-intubation sedation, where they gave him 100 micrograms of fentanyl. At 46 minutes, they initiated transport and gave him 250 milligrams of ketamine. At 53 minutes, they obtained a 12 lead, which looks narrow complex, no peak T's, and sinus in origin. He got another dose of fentanyl at 57 minutes, which was about 16 minutes from the last dose. And 68 minutes, he got 200 milligrams of ketamine, arrived to the hospital at 71 minutes. In reviewing this case, early and complete vital signs, high quality CPR, management of BFib with defibrillation and CPR, intubated, med selected, included rocuronium as opposed to succinylcholine. They used video laryngoscopy, bougie, and recorded and obtained an end-tidal CO2. They did get a 12 lead. They did not initiate transport immediately. They waited until the patient was stable. And areas for improvement is, which we'll gather here shortly, is the reminders what the contraindications to CPAP are, and then making sure that your documented procedures, there was 2 missed IVs before the IO was placed, so making sure that we document even our failed attempts or our unsuccessful attempts. And then making sure if you're in a PEA arrest that you're still thinking about H's and T's if it wasn't identified earlier. And then remembering that the max dose of ketamine is 200 milligrams, not 250. Anybody else have any questions, concerns?
No, I was just adding to what you said. It's great. It's a great choice to use rocuronium for this patient because he's set up renal failure with all those days on the couch not taking PO. And then I also thought the crew did a really good job of starting with the IGL, ventilating with the IGL, and then managing everything, not letting the need for intubation take over. It was all really well managed, and they also, they tried IVs, didn't get IVs, went to an IO. It all just flows like really well managed, difficult patient.
Yeah, agreed. And the documentation of the procedure, but I tend to believe that there may have been something else that we didn't document in our pre-hospital, because the hospital alludes to it that somebody's speaker is on if you have a question or want to bring up a thought. All right. So the physician's documentation stated that EMS had pointed out that the breath sounds were abnormal. But anyways, initially his temp was normal, heart rate of 96, blood pressure 105/78. He was, I don't know if he was over breathing or if he was being ventilated, but he was 27 for a respiratory rate, and his initial SATs were 79%. He went back into cardiac arrest. He had CPR initiated. He was transiently in VTAC that was shocked out of it at 120 joules. ROSC was achieved, and he was given 150 milligrams of amiodarone. At some point, they got a chest X-ray, which is what we're looking over here on the right. I think we probably maybe look at it. Well, they noted that with following ROSC, his blood pressure was pretty substantially low, so they kept him on an epi-drip for blood pressure management, and they obtained a chest X-ray, which just kind of like orienting you. Here's the right side, here's the left side. The left side is completely opacified. There's some lung markings on the right side. You can see this is the ET tube, which is shifted over to the right. So this is interpreted as pleural effusion with mediastinal shift, or kind of like a tension physiology. Given that chest X-ray, They placed a chest tube and immediately evacuated about a liter of purulent material or fluid. Because of this finding, they went ahead and treated him with broad spectrum antibiotics for concern for pneumonia leading to empyema. His labs were significant for an elevated lactate of 11.3. He was acidotic with a pH of 7.0, and his PCO2, or you can think of it like his end tidal, was elevated at 67. His kidney function, remarkably, was not as bad as you would think given his poor PO intake. And stasis, it was 1.1. Potassium was normal, but his white blood cell count was substantially elevated. They got a CT of his chest, and he had bilateral pleural effusions, but the left greater than the right. They say pleural effusions as they don't determine if it's like exudative, which is like purulent, or transudative. And they noted that he had a small left pneumothorax. He was admitted on May 30th and wasn't discharged until the 19th. In the ICU, he was prone because of continued hypoxia. He was on multiple pressors, norepi, vasopressin, and he was also treated with stress dose steroids because he was so hypotensive refractory to pressor therapy, thinking that there may be some adrenal insufficiency. His chest tube would drain out about 1.5 liters of pus on a daily basis for the first couple of days. His blood cultures did grow out strep intermedius, which is a common pathogen related to empyema. Hospital day 3, because of his empyema, he was given intrapleural TPA to try to decrease long-term morbidity of having an empyema, decreasing fibrosis potentially. And then on hospital day 5, because he wasn't having improvement, he was still spiking fevers. He had a second chest tube placed by interventional radiology. On hospital day 7, they believe that, at least by subsequent x-rays, they noted that he was having an interval increase in his pneumonia by imaging. So he went to the OR for a thoracostomy drainage and a wound vac. On hospital day 14, they were able to remove his first chest tube. And on hospital day 16, because he wasn't able to be extubated, he had a tracheostomy placed and he had a second chest tube removed. So kind of a crazy case, especially since the crew was talking to this patient. And I mean, I'm not sure if anybody, yeah, thank you, Mark. Empyema is pus or purulent fluid within the pleural space. I think that that if the EMS crew did notice abnormal breath sounds that they conveyed to the hospital, even if it's later in the game and not earlier, that's something that we should definitely document in our chart, especially because that is something that draws attention to the hospital resuscitation team. But anyways, empyema is pus in the pleural cavity. In the United States, there's about 32,000 cases a year. And it's usually associated with pneumonia about 70% of the time. And of the pneumonia cases that we have, about 20% are associated with an empyema. It also can be caused by post-surgical issues or post-trauma related from an infection that penetrates the chest wall. Risk factors are any of your immunocompromised patients. So either that they're immunocompromised because they're taking immunosuppressive drugs, or they're a patient that doesn't take good care of them. Maybe they're of themselves, like an alcohol abuse patient. Reflux puts them at higher risks, and diabetes, as well as IV drug use. So this usually happens because when a patient has pneumonia, it leads to inflammation, which can by capillary leak into the pleural fluid, and then the bacteria that is in the lung can colonize that fluid. Patients usually present with respiratory symptoms such as fever, cough, shortness of breath. They may complain about having productive sputum, and they may have pleuritic chest pain. So these are patients that are going to sound a lot like your pneumonia patients, but may actually go on to have an empyema. And these are usually a prolonged presentation. If these are patients with pneumonia, they have pneumonia and then they end up developing empyema after the fact. These can be identified sometimes by physical exam, either by diminished breath sounds or by chest auscultation, which I can't tell you that I do a lot of chest auscultations, but if you're really a master of the physical exam, you could potentially identify this. What's more likely for it to happen, to be identified, is by chest x-ray. And depending on the view that we are looking at, it can detect as small as 75 mLs of fluid, but typically it's closer to at least 200 cc's of fluid before it's identified by chest x-ray. Ultrasound, bedside ultrasound is fantastic for us to identify these even in the pre-hospital setting. And then of course our CAT scans can help get to the point of a diagnosis or actually drainage of it to prove that it's an empyema. And then treatment is going to be draining the pus and starting antibiotics for a prolonged period of time. And then some patients may need to go on to having surgery depending on what their conditions are. And then I have here tension pneumothorax. I wanted to bring this up because the question that may come up is, can you get a tension from pus or from fluid as opposed to what we usually consider as like air, I guess, or blood. But anyways, yes, you can. It's when so you can get these tension pneumothoraxes when the empyema causes a pneumothorax, which, reminder of a pneumothorax, is a collapse of the lung. So it doesn't have to be a puncture of the lung. It can be by compressive forces that collapses the lung. And that if you have increased intrathoracic pressure, such as positive pressure airway maneuvers, either by BiPAP, CPAP, or by intubation, you reduce the venous return, which when you reduce the venous return, you reduce the cardiac output, and you can also further exacerbate the displacement to the good lung that's remaining. So a reminder to really pay attention to your physical exam if you are, which you should be doing on your patients, especially if they're complaining of shortness of breath, and identifying your H's and T's when you are dealing with a PEA patient and trying to figure out what are reversible causes. One of the questions I kind of thought about in my own head about this is that it sounds like EMS had identified this. They had conveyed that to the physician that the patient had abnormal breath sounds. And I guess my question to you guys is, if you thought this person had a fluid collection in their lung that they've arrested, you noticed that there was abnormal breath sounds, would you needle them? So I think all of our stuff is about trauma, and some spontaneous stuff more like in regards to pneumothorax from like bleb or from your tall male patients. So I think that if you suspected this, especially if this is a patient in extremis, peri-arrest, or actually gone into arrest, that if the patient's in arrest, I think that if you have abnormal breath sounds, I would advocate that you manage your H's and T's. But if the patient isn't in arrest, I think a phone call to online medical control would be warranted and appreciated to help weigh in on that decision. Does anybody else in our MPD's office have any thoughts about that?
So I agree with what you said. I mean, if you have a patient that's circling the drain, and you have abnormal breath sounds, and especially if they get worse after CPAP, it makes sense to think about bending the chest. And the downside for someone that sick is pretty minimal. You probably, in someone like this, you may get air. You probably won't get pus up because one, because the pus is normally dependent and we needle the front of the chest. Two, the catheters probably aren't big enough to express pus. But if there is a little bit of air in there, and you decrease some of the tension, you can potentially really help the patient.
Yeah. So I was just kind of looking over our CPAP criteria, and you know, the indications would be a patient that's short of breath with either fluid like heart failure, pulmonary edema, or non-cardiac causes of pulmonary edema. Maybe that would be like you're looking about your drownings or something along those lines. If they have a difficulty with breathing from reactive airway problems, but even as you can see, it's listed as pneumonia. Um, and if they're a pediatric that can tolerate the procedure. And then the absolute contraindications are going to be respiratory arrest or inefficient respirations. They're unable to protect their airway because they're unconscious. They have facial trauma or problems with mask seal because of burns or fractures, or if they have a pneumothorax. And then reminder, the relative is that their mental status is potentially diminished a little, but not unconscious, or they can't tolerate it because they're claustrophobic, or you don't have the proper adapter for a tracheostomy, or the pediatric patient doesn't tolerate it, or you don't have equipment that fits them appropriately. Cool. Anybody else have any questions, thoughts about that case? It was a really great case. The ER doctor that was taking care of the patient had brought it to my attention and was like, it's pretty crazy to be a young person and to present awake and then arrest and then have this type of infection that wasn't managed for a prolonged period of time. And he actually was very complimentary about EMS. In fact, it's kind of the theme in some of these case reviews this month. All right. Well,
yeah, just to agree with that. I mean, there's clearly someone that dies without EMS care, and especially, it sounds like the first response crew, managed this guy for a long time and did a good job with it.
Yeah. The next case is of a 69-year-old male with a table saw accident. EMS was dispatched to a hand injury, and they found that the patient was alert. His airway was open. He was protecting it. His skin was pink, warm, dry, and he somebody, I think, just logged in. And if you could put your recording on mute, please. So he was found to have moderate bleeding, but a strong pulse. Vital signs were obtained shortly after patient contact at 7 minutes. He had a temperature of 97.6, heart rate of 60, blood pressure 152/97, respiratory rate of 20, and a blood glucose of 127. His past medical history included coronary artery disease, hypertension, and Parkinson's. He was on the expected medications for this condition, not on any blood thinners. And the history was that he injured his right hand after removing the chainsaw bar because the blade had cut through the chainsaw bar, and it was still moving when he was trying to remove it. It cut all of the fingers of his right hand, but did not amputate them. This occurred at 10:55 in the morning. At 6 minutes, an IV was placed. It was noted that the patient had moderate bleeding controlled with direct pressure with a towel that the patient was providing. At 7 minutes, the vital signs that I reported to you, and at 8 minutes, he got his first dose of fentanyl at 50 micrograms. They documented a physical exam that he had good circulation, movement, and sensation in his two upper extremities. He had a laceration to the right hand finger along the anterior aspect. They noted that there was partial thickness to the pointer finger. There was a full thickness laceration to the middle and the ring finger, and then a partial thickness to the pinky and the thumb, and that the bleeding was controlled with sterile dressing, and that the patient was ambulatory. They initiated transport at 10 minutes after patient contact. They got multiple sets of vital signs that were stable. He was a little bradycardic, but otherwise kind of borderline hypertensive. SATs were fine despite getting pain control. And at 42 minutes, he got another dose of pain control. And at 62 minutes, he had bandaging placed. And speaking with the crew, they stated that they did sterile dressing with a Coban, but no external direct pressure, and that the bleeding was controlled with just this gauze and elevation above the heart with an ice pack on the fingers. Their Pulsera report was super detailed and complete. This is a little excerpt of it. So chainsaw versus finger, full thickness cut transversely across 2 middle fingers on the anterior aspect of the right hand, partial thickness on 2 other fingers in line with the other cuts and thumb. Moderate bleeding initially controlled with direct pressure via sterile dressing and elevation above the heart. Good distal sensation and movement on injured fingers, and that he accidentally grabbed the chainsaw bar while it was still running, not on thinners, controlled with fentanyl. So in reviewing this case, I thought that we did a great job of getting off scene, not having a prolonged scene time, 10 minutes from patient contact to initiation of transport, and that's with an IV, pain meds, and vital signs. They documented really thoroughly. It was very clear that they took the time to do the assessments and to communicate that not only in their own documentation, but through Pulsera. Treatment was appropriate and they obtained serial vital signs. So the only thing that I would say is our description of a pressure dressing. So in the emergency room, they were met to a full trauma team activation. The initial vital signs is he's afebrile, his heart rate's still bradycardic at 45, still a little hypertensive at 154/89, respiratory rate of 10, SATs of 96%, and they document that he has lacerations to the right third and fourth digit with exposed tendon. They got a hand x-ray, and you can kind of see the soft tissue defects involving the second, they don't count the thumb usually, so first, second, and third finger. There was question to maybe an open fracture, but it was kind of like a hedging, not really sure, could be clinically correlate. They consulted orthopedics who agreed to take him to the operating room for closure and irrigation. He was discharged on hospital day 3. So the reason why this case is being brought up is because the EMS crew wasn't expecting a full trauma activation. I think that it's important to understand what the criteria is, and making sure, I'm not asking for any of us to document or withhold information, but to make sure that we are documenting and conveying exactly the same kind of information so that the hospital can make sure to activate appropriately. So bleeding control, when I think about pressure dressings, I think this is a kind of a good example with the Stop the Bleed campaign. So you're taking gauze or quick clot and you're covering the wound. If the wound is big, you're stuffing that gauze or quick clot into the wound, and then you're applying continuous pressure with both hands on top of the bleeding wound. You're pushing down as hard as you can, and you're holding pressure until the bleeding stops. And when the bleeding does stop, you're wrapping it, and you're continuing pressure until relieved by medical responders. So that's the kind of thing I'm thinking about in my head when I think about tourniquets and pressure dressings, is like hemorrhaging, that you have to put, you're binding in these large wounds, you're putting both hands, you're putting, firm pressure, pushing down as hard as you can, and not letting go of it until you're relieved of your duty by the next provider. So that's the kind of thing I'm painting in my head to tell to you guys, so that we make sure that when we communicate to the hospital pressure dressings, that's the kind of things that we're probably really trying to convey. So for our area, for Clark County, we have the red and yellow criteria, and this is this has been in our protocol now for at least a couple months. I'm not going to read these out to us because of the sheer amount of details in there. But those are the red criteria, the injury patterns and the mental status and vital sign changes. They're made to mirror our trauma criteria for the hospital, but they're not exactly the same. And even this actually in this red criteria, and the very bottom part is active bleeding requiring a tourniquet or wound packing with continuous pressure. Wound packing, I think, would be binding clot, your hand directly on it, holding as tightly as you can to control bleeding. And then I took a picture of the trauma criteria sitting next to the charge nurse, and they look pretty similar. But the full trauma activations are going to be regarding blood pressure, depending on their age, if they have any penetrating injuries to their core, such as their head, their neck, their chest, their abdomen, their groin, or if they have any penetrating wounds that are proximal to the knee or the elbow. So we're worried about, large artery involvement. If they have any crushed or degloved, mangled, pulseless extremities or amputations above the wrist or the ankle, if you think that there's a spinal cord injury and there's neurological deficits, paralysis is pretty obvious, but if there's other deficits like weakness in their upper extremities, as we talked about in previous case reviews, if the patient's intubated, no matter if they're intubated and there's trauma, this is a full trauma. Patients with respiratory compromise or patients in need of an emergent airway, any patient that has a GCS less than 9. Oh yeah, just looking at the chat here. I'll get to that in a second. And then transfer from another hospital and receiving blood and active bleeding requiring a tourniquet or wound packing with continuous direct pressure or the ER doc's discretion. So just looking at the chat, did the person who made the comment, do you want to go unmute and talk about it, or you just want me to read it or not read it?
You can go ahead and read it. I was just curious. You're explaining why if we don't want to admit information, we want to make sure and clearly this provider had a full description of the injury, and he made it a green. And I guess instead of omitting information, how would you like us to explain that so we get it across that it was just lightly, the bleeding was lightly controlled or controlled with just light pressure? That's a good question to have back and forth.
Yeah, I think like light pressure, I think that, and it's a good, so when you've got whoever's on the other side of receiving us, if that's going to be the charge nurse, which is usually the case, or maybe whoever's sitting in for the charge nurse, they're looking at these, these full and modified criteria, and they're looking for buzzwords, right? So wound packing with continuous direct pressure. So I think that, one of the points that we made was that this was a green activation. So that seems to be a disparity to what this patient actually was met at. So ideally, the charge nurse would communicate to through Pulsera, are you sure that this is not, you want it green? Maybe communicate is like this, like hemorrhaging kind of thing. And then I would say that you can say controlled with dressing and wrapping or Coban, or I think that so in speaking, because I ended up talking with trauma about this because I was talking to trauma about another issue, and they said when they see direct pressure, they're going to activate this as a full trauma each time because they don't want to be behind the 8 ball. So just be aware of our documentation. If you think that the patient needs a full trauma activation, then you'll be getting that. So it was just more of like bringing it to everyone's attention that it's not just tourniquets. It's going to be pressure dressings that they're going to interpret as hemorrhaging patients that need to be immediately evaluated and resuscitated. Anybody else have any questions, thoughts, feelings about this case or similar thread?
I guess, is it your sense that this patient is better served by being a full trauma because of the direct pressure, or that this was just a miscommunication? And if they'd said, like, managed, no, not needing active direct pressure right now, then that would have gotten the patient what he needed.
So if you're asking me, I'd just be Monday morning quarterbacking. But if you're asking the crew, I think they're at least one of the representatives are on. But to me, it didn't seem like they needed a full trauma. It didn't seem that they needed the operating room to be freed up and for the operating room staff to be in the emergency room awaiting this patient to take them urgently or emergently up to the operating room. But I wasn't involved in this patient's care directly.
But and so you're saying if they had not said that they're giving continuous direct pressure, then that patient
Yes.
wouldn't have gotten the same response.
Correct.
Got it. Okay, thanks.
Mhm. If nobody else has any other questions or thoughts about that, I'll move on to the third case. So the third case was brought to with MPD's attention by one of the ER physicians. This was a case of a 16-year-old male. EMS was called for allergic reaction. Patient was found to be awake. He had an open airway that he was protecting, and his breath sounds were clear to auscultation. He was noted to be flushed. He was warm, he was dry, but he had hives, and there was no signs of any active bleeding. Vital signs were obtained immediately upon patient contact, noted to be tachycardic at a rate of 130, blood pressure of 115/66, respiratory rate of 18, SATs of 98%, average weight male. His past medical history was that he was allergic to tree nuts and that no meds were documented prescribed to him prior, but I think that might have just been an oversight based off of the further history you'll get here shortly. History of the present illness is that he had just finished a workout and he ate a protein bar approximately 90 minutes prior to initiating 911. After the fact, he found out that there was cashew butter in it, which is one of the nuts he is allergic to. He developed hives and he became itchy. He administered his own EpiPen and had taken some Benadryl. He felt a little better initially, but then started getting worse, where he was starting having itching, hypersalivation, rhinitis. He had no shortness of breath at any point, no oral swelling. He had no complaints of a scratchy throat, chest pain, or any abdominal pain or GI symptoms. So this call occurred at 1626. Vital signs as reported. They noted that he had diffuse hives throughout his body. At 4 minutes after patient contact, they gave him 0.3 milligrams of IM epi. They started a line and checked a blood glucose, which was normal. Because he had two systems involved, his skin and then his upper airway kind of symptoms with his, rhinitis and his itching, his hypersalivation. They decided that they interpreted this as an anaphylactic reaction because two systems were involved. So at 8 minutes, they started him on an epi drip at 2 mics per minute. They noted that hives improved after the epi was infused. At 14 minutes, they gave him 125 milligrams of Solumedrol. Remember, this is a patient that has adult weight, even though he's a pediatric. And they continuously monitored his airway, breathing, and vital signs, noting improvement in documentation. At 17 minutes, another set of vital signs were obtained. He was no longer as tachycardic, now at 110, blood pressure 118/64, respiratory rate of 16, SATs of 100%, and afebrile. At 21 minutes, another set of vital signs were obtained and initiation of transport at 25 minutes. For the remainder of the transport, the patient remained stable. They got serial vital signs and complete vital signs. They documented in their chart that the vital sign delayed a treatment. The vital sign was delayed because of rendering treatment for his anaphylaxis. And then once they treated his anaphylaxis, they went back to doing every 5-minute vital signs. And they also even documented holding albuterol because the patient had no shortness of breath and no wheezing or reactive airway symptoms. So they didn't feel like it was indicated, which I think is great for them to identify that it could be used to treat this patient, but he doesn't have any symptoms that it would be actually improving. So in review of this case, the good is that they transported this child. I mentioned that not because I read it in the documentation, but the ER doc had said that the first on scene was talking about doing a refusal, and when the transporting agency arrived, they had stopped the refusal and initiated transport with the child. Recognition of anaphylaxis, aggressive management of anaphylaxis, and documentation of delays in medical decision making, as well as monitoring. The only thing that I could even say is if he has a history of anaphylaxis, what has his responses been? Has he required hospitalization, intubation? But really, this case was really well managed. Dr. Mock, do you have anything to add to that?
No, I don't.
Okay. So in the emergency room, the ER doc had asked the patient if he's ever been hospitalized or intubated, which he had not. His vital signs upon arrival was a tempo of 99.4, heart rate of 117, blood pressure of 99/61, respiratory rate of 21, SATs of 100% on room air. EMS had given him basically everything that he would need, so the only thing left for them to give was famotidine. After, I want to say an hour and a half, they tried to wean him off the epi, but he developed hypotension, so they put him back on the epi shortly after stopping it, and it actually increased to 0.03 mics per kg per minute, and they initiated requests for transfer to Dornbecker for admission of this kid for anaphylaxis. The patient was transferred to Dornbecker. The next day, they were able to wean him off the epi drip. Off of epi, had one transient hypotensive reading, but he wasn't symptomatic, so they didn't resume his epi drip, and then he was able to be discharged on the third day, with a prescription for a refill on his EpiPen. So, as a reminder about anaphylaxis, anaphylaxis occurs from exposures most of the time, but can be idiopathic. So food, medication, insect stings, or compounds. And then worldwide, only about 3% of the population will develop anaphylaxis, and it's usually more prevalent or more presentations occur in younger patients. This is just a little cartoon about the sensitization and the re-exposure phase. So it's IgE mediated. There's an exposure to an allergen. An antigen presenting cell captures the allergen and binds it to the CD4 helper cell that goes on to activate a B cell to produce antigen-specific IgE antibodies that go on to be bound to mast cells and basophils. So when there's re-exposure to the antigen, we end up seeing release of the mast cells and basophils that lead to the symptoms that we see with anaphylaxis. So in the basophils and mast cells, there'll be release of prostaglandin, which leads to bronchoconstriction and pulmonary and cardiac constriction, leukotrienes, which are also contributory to bronchoconstriction and vascular permeability, platelet activating factor that leads to bronchoconstriction and vascular permeability. Kind of get the gist here. TNF alpha that goes on to create more of an inflammatory process, and then histamine release, which increases vascular permeability. So anaphylaxis can be, usually it presents mild, but it's really dependent about the mode of exposure, maybe how the symptoms are going to manifest. Patients can have all kinds of symptoms, which I kind of list here in the lump in throat, clearing of their throat, hoarseness, hypotension. They could pass out, they can go into cardiac arrest. But this is a list here of some criteria that can be helpful. Let me see if I can move this. Can't. Oh, there it is. One of the following with onset within minutes or hours. So respiratory symptoms, hypotension, or end organ dysfunction, such as syncope, incontinence, or loss of tone. And then likely exposure to an antigen and symptoms involving any two of the following body systems: skin, respiratory, hypotension, and GI. It does not require that these criteria are met, but just gives you an idea of the presenting symptoms or complaints that the patient might have. The more rapid the onset and progression, the more likely for it to be severe. But I've definitely have had cases where they've had a delayed reaction of anaphylaxis upwards of 12 hours after exposure with latex in particular. And then some patients will have biphasic presentation. So if you or any of your loved ones have ever presented to the emergency room, instead of just treating you and deciding if you get admitted or discharged, oftentimes there's 3 to 4 hours of observation to make sure that you don't have that biphasic response, although the data shows that it's more like upwards of 6 to 8 hours before they have a response where they start to look anaphylactic again and needing to be redosed. 20% of the time they'll have a biphasic presentation, and of the anaphylactic ones, only 3% of those will have that biphasic potential. So treatment's going to be early recognition and treatment, especially when they're not straightforward hives, shortness of breath, like lip swelling or tongue swelling. It can be hard to recognize that as it is. And then epinephrine, steroids, Benadryl, or antihistamines, IV fluids, airway securement, and potentially bronchodilators. So when reviewing our county protocols, mild reactions, that's our patients that have hives, skin, or itching symptoms only get some Benadryl. Severe reactions such as severe shortness of breath, laryngospasms, shock, or angioedema are going to be treated more aggressively with epinephrine. And then potentially with an epi infusion, as well as IV fluids if they are hypotensive, Benadryl, albuterol for wheezing, and then steroids without options of Solu-Medrol or dexamethasone. If the patient doesn't respond to these agents, you may need to add additional consideration for norepinephrine, and then the pediatric doses being adjusted for the patient's weight. Cool. Anybody have any questions, thoughts, concerns about that one? The ER physician, go ahead.
Oh, no, it sounds like this a patient appropriately got transferred, but the vast majority of kids with anaphylaxis get treated and observed in the ED. So and then discharged from the ED. So no need to go across the river with someone like this.
Yeah, good point for sure. And that's I guess that's a good point to say that they didn't initiate transport on this kid until the kid failed epi weaning. So if they, to further supporting what Dr. Mock just said, if they thought that this kid was definitely, just because they were on epi drip, had to be transferred, that would have occurred immediately after EMS left. But they waited 90 minutes, an hour and a half later, after failing titrating him off those meds, that they knew that they couldn't keep the kid there. And I was just going to say that this ER doc had reached out to me to commend the crews for what could have been easily a, hey, this kid's not that sick, or the kid doesn't necessarily need to come by us, or that maybe this kid doesn't even need to be treated for anaphylaxis, maybe more mild symptoms, and was really, really supportive, bragging about how impressed he was with the crew. All right, last case is of a 41-year-old male. EMS was called for a possible seizure. The patient was altered when they made contact with him. They document that he's unresponsive on the AVCU assessment, in that his airway was open, but he wasn't protecting it. He was tachypnic, he was gray, he was ashen and diaphoretic, but there was no signs of active bleeding. Vital signs were obtained shortly upon patient contact, heart rate of 118. Blood pressure couldn't be obtained because of him thrashing on the couch. His respiratory rate was 36, his SATs were recorded at 90%, and his GCS was 5. No past medical history was obtained from either the patient or family members, neither were medications. They document that there was the home was in poor condition. The family was poor historians. They knew how old he was, but they didn't know his birthday. They said that, just to give you an example of like how close they would be with this patient, they stated that he was having a hard time putting on his shoes and acting funny, so that's what prompted them to call 911. They thought that he might have had a seizure. He has no history of a seizure, in that they state that he wasn't complaining of anything, he didn't have any falls, in that they went on to tell EMS that his alcohol consumption is no different than anybody else's. They later, after further questioning by EMS, thought maybe he wasn't feeling good the day before because he had vomited. And patient contact initiated at 1813. They find this patient sitting on the sofa. He's rolling around side to side, making it very difficult to assess him or to get vital signs. Vital signs, as reported to you earlier, at 4 minutes, they start an IV and they infuse over the time course 1 liter of lactated ringers. They place him on a non-rebreather mask. They noted that he was unresponsive and groaning. At 12 minutes, they put a NPA in and they start to bag him, and they're suctioning him because of his secretions. At 13 minutes, they repeat another set of vital signs. He's got a heart rate of 115, blood pressure of 148 by palp, respiratory rate of 17, SATs of 91% despite the NPA BVM, and end tidal is 50, blood glucose is 90, and his temp is 100.4. At 16 minutes, they give him 200 milligrams of ketamine and initiate the DSI protocol. They place an eye gel to ventilate him, and I'm going to go over to the right-hand side here. So they attempt to lay him down off the couch because of how unstable he looks, or potentially sick, but he would not cooperate. They were able to put fast patches on him, but it was very difficult due to the severe diaphoresis that the patient had. And they noted that he had very poor hygiene, particularly in his folds with yeast infections. At 21 minutes, they give him rocuronium. Unfortunately, I think I may have omitted some vital signs because they definitely had more vital signs, so I apologize. But based off of my memory, the patient's SATs were at goal above 94%. And at 22 minutes, a 12 lead is obtained after he gets rocuronium. So it's narrow complex. It looks a little bit fast to me, and I don't see any Q waves, normal axis or R wave progression. But anyways, they intubate him with at 23 minutes with an 8.0 ET tube, PEEPA 5, and 10 centimeters of water. 25 minutes, they give him his pain sedation post intubation package. At 26 minutes, they initiate transport and they notify the hospital that they think that he has sepsis. They put a second line in, and at 32 minutes, they give him ketamine for his sedation. And at 38 minutes, they arrive to the hospital. So in reviewing this case, I really felt like this crew did a great job with documentation, getting vital signs, getting a blood glucose, and checking for hypoxia, managing that hypoxia with BLS, and then further on with DSI, achieving goals of SpO2s to move forward with intubation, and then the choice of their induction agents. As you can see, this crew did not use succinylcholine. And then getting a 12 lead in their clinical concern for this patient. I really didn't have any areas for improvement. I don't know if anybody else on the call had any other thoughts.
No, I agree.
Okay. So in the emergency room, he was noted to have a temp of 38.4, heart rate of 98. He was borderline hypotensive at 104/78. He was tachypnic at 25, and his stats are 94%. And mind you, he's intubated at this point. His labs came back with a moderately elevated white blood cell count. His lactate was pretty elevated. I believe it was like 7. And his sodium was quite low at 116. His blood glucose was a little bit low at 68. They had previously checked it with, it was 90 with EMS. And then his lipase was elevated, suggestive of pancreatitis. Given his hyponatremia, his low sodium, they thought that this report of seizure in the pre-hospital setting was probably accurate due to his hyponatremia. The ER doctor consulted the kidney doctor's nephrology and had told him about the patient's presentation, concern for seizure, and his sodium. And so they went ahead and treated him with a small amount of 3% normal saline. He went to the ICU where he coded. He was given 1 milligram epi, and they were able to get ROSC back on him shortly after initiating CPR, and that his blood cultures never grew out any bacteria. He was able to be extubated, but he was continued to be hypoxic, so he required a high flow nasal cannula. They worked him up for that hypoxia with a CAT scan of his lungs and the blood vessels, and they showed no pneumonia. Actually, they did show pneumonia, but they didn't show pulmonary embolism. So when I looked him up 2 days ago, he's still admitted, and his diagnosis is severe potomania, hyponatremia, respiratory failure, pneumonia, pancreatitis, and sepsis. So the additional information is that he has a history of autism, and he was a bigger drinker than his family had alluded to. So I thought this might be a good time to kind of talk a little bit about beer potomania as a cause of hyponatremia. That's a lot of words. I apologize for the amount of words and not as many pictures. And hopefully I don't make you guys glaze over, but it's a condition where a patient they have a low serum sodium because they're an excessive drinker, and then the literature states that excessive drinkers are people that drink more than 5 beers per day. So this is particularly in regards to beer consumption, not to hard alcohol. And another way you can think about it is that these people drink a lot of free water, which is the beer, and they have a poor diet. So normal function or normal physiology is that when the kidneys are functioning normally and your diet is normal, that the combination of diet and renal function allows you to remove up to 900 milliosmoles per day, and that your urine can dilute. If you have any comments, feel free to talk, but if you don't, please put yourself on mute. So your urine's ability to, I don't know, Mark, if you could silence whoever's not silence.
Fixed it.
Okay, cool. So max urinary dilation of 50 osmoles means that a patient with normal renal function can excrete up to 20 liters per day, and that the person's ability to clear free water is dependent on how many osmoles that they have in their diet or in their body. So abnormal physiology is when a patient has less than ideal dietary osmoles. And that means that it affects their ability for their kidneys to excrete water. So beer in particular has very little nutritional value. It has only trace amounts of sodium, just a little bit of protein, which allows for a little bit of protein, and then it has some calories, so it doesn't lead to proteolysis or urea production. So a patient that has beer potomania usually has such poor dietary consumption that their intake of I guess based dietary solutes is in the scale of like 225 milliosmoles per day. So that means that if a patient drinks more than 4 liters a day, that they cannot they cannot normalize their sodium, and that they end up reabsorbing water, and that leads to them becoming hyponatremic or low sodium. This picture here, I'm just trying to move the little thing here. Okay, so this picture here kind of talks about like a kidney function on a simplified diagram, but basically from the glomeruli, yeah, filtration, proximal, then Lupa Henle, anyways, lots of stuff. But the point is that with beer potomania, that the water is reabsorbed, leading to dilutional hyponatremia. So the complications of sodium being low, no matter the cause, is seizure, confusion, and potential coma. Management in regards to beer potomania is going to be that they have nothing to eat or drink for 24 hours as they try to figure out the correction. You can think of it. They get no IV fluids unless they're symptomatic, because if they do get IV fluids, they end up diuresing briskly, and that can lead to vast dramatic changes in their sodium. If they do get IV fluids, it's only for a small amount for a small amount of time, and they're all admitted to the ICU because of the concern of, well, I shouldn't say that they all are, but depending on the region, but most of them should be admitted to the ICU for close neuromonitoring and sodium rechecks, because their sodium is being checked every 2 hours, because they need their sodium to not be corrected greater than 10 milliequivalents per liter in 24 hours, or greater than 18 milliequivalents in the first 48 hours, because correction too quickly can lead to a condition called osmotic demyelination syndrome, where they can cause trying to remember the I think Dr. Mock, it's
Central pontine demyelination.
Yeah, but I'm trying to think, it's when they the water gets pulled from their myelin, right? So they get shrinkage. Yeah. So they can present with dyspnea, dysphagia, dysarthria, and ataxia. So they can kind of look like a neuro stroke patient, but that's not from a stroke. So I think that's the best for what information was available to EMS for reviewing the Southwest region protocols is sepsis, since we didn't know what the patient's sodium was, and we don't have a sodium protocol anyway. And then we weren't necessarily convinced that the patient actually had a seizure given the poor historian. So sepsis, maintaining stats above 95, and known or documented infection. I think that if I remember correctly, the patient's temp was 100, the respiratory rate was fast, the heart rate was fast, if 2 or more of the above, and the blood pressure or altered mental status. So the patient qualified with altered mental status and notified the hospital, which was done. They can give up to 2 liters. They gave 1 of lactated ringers preferred, and making sure that they're not over resuscitating by monitoring the MAPS, the JVD, and the lung exam. If they're not responding, pressors would be in order. So, anybody have any questions, thoughts, comments on the last case?
No, that's a great description. The only thing that I would add that helped me to understand the beer potomania is that people who are alcoholic, who drink pretty much anything other than beer, like they don't have to drink so much free water to get the amount of alcohol that they need. But if you're a beer drinker, you have to get in a lot of free water to get the amount of alcohol that you need. And so that can drop your sodium. So it just reminds you of the critical importance of eating nuts while you're at the bar.
Yeah, actually, you reminded me in my research of this material that it doesn't really, beer potomania or hyponatremia in beer consumers doesn't really happen in the UK. And they postured that it was because of the salty snacks that accompany them at bars.
Yeah, and the beer's more concentrated, like, 3-2
Yes.
beer is the worst for this.
Yes. Yes. Cool. Awesome. That's all I have. And just a review of the topics. Make sure you listen to lung sounds. If you find them to be asymmetric or absent, be pretty unusual, and be really conscientious about positive pressure in the form of CPAP or intubation, especially if the patient starts to decline. It might really push your hand to manage that abnormal physical exam finding. Anaphylaxis can be really kind of straightforward with a kid or a person that has a known exposure where they have swelling of their airway or their face, but they can be subtle or not previously diagnosed. So just keep your suspicion broad. And then to me, when I'm thinking of direct pressure and tourniquets, I'm thinking like really aggressive bleeding control. And then just the hyponatremia portion of things is that with alcoholics is that their dietary intake is lacking because of their choice to consume more alcohol or beer. So they can present, it can be kind of difficult, these patients, where they might be altered and we're like, is it because they're intoxicated? Is it because they've fallen and hit their head previously or today and now they have a subdural? So just being aware of getting a good history and a good exam if this patient has any focal neurological deficits or history leading to that suspicion. So this one had a couple things with the infectious process as well as the poor PO intake leading to hyponatremia. Quick references. And any questions? Awesome. Well, thank you guys for your attention. Sorry I went over a little bit. Hopefully that this was interesting for everybody.
Thank you.
Yeah,
Thanks, Dr. Gadwal.
absolutely. Have a great remainder of your July. See you in August as well.
Mark, did you say